With that, we welcome Erik Hohmann from Australia, who's going to tell us about early versus late reconstruction if your repair hasn't worked for multiligament knee injuries. And look forward to hearing what he has to say. Thank you.
Good morning. I've been asked to present to you early versus late reconstruction, but really this is very boring, going back and forth and bringing you arguments whether to do it early or late. So I've decided I use a slightly different approach and talk you through a meta-analysis comparing early versus late so that you understand the controversies a little better. So in the 90s, the late reconstruction was an absolute no-no and run by Donald Shelburne. The reasons was it results in stiffness, it causes arthrofibrosis, and the return to work is reduced. 10 years later, run by Chris Harner, maybe his group in Pittsburgh says, yes, no, you've got to reconstruct it because they have better clinical and functional outcomes, and you do protect your articular cartilage in your menisca if you repair them early. So let's go back and say, why not repair them late? Well, you have associated muscle atrophy, which results in reduced strength. And we do know from ACL surgery that even though we do repair these ACLs early, they have muscle atrophy and reduced strength at 1 year results. And all your patients will tell you, hey, I was okay after a year, but it really took me 2 years to go back to my normal function. It also facilitates return to work and the economic consequences for both the patient and society. If you repair them early, there's a higher chance of returning to a normal knee function. What about repairing them late? Well, the argument is here. Restore your range of motion first, allow your soft tissues to recover, swelling to be reduced and inflammation, and you may have less wound complications when you do the surgery. Now that's from the man himself, Schenk, who wrote a study about his experience for over 20 years, published 2 years ago. And he just used 2 examples. And what he basically says is, if you repair them early, you have a better clinical outcome. But you have to be very careful in interpreting these scores because the minimal clinical important difference for your LISOM score is 6, and for your IKDC score is 13. So even though you may see that there's a great difference between early and late, they're clinically really not important. If you look at the functional tests or the hopping tests, you may see that late reconstruction is doing much better in terms of function. But once again, the standard deviation for your hopping test is 15%. So at the end of the day, it means nothing again. So with this previous speaker in here, there's really no evidence that allows you to conclude whether you should do it early or late. There are no randomized trials, and the studies are relatively small. So what about meta-analysis? What is a meta-analysis? It's nothing else but a systematic review of the literature. And whenever we run into a problem, I hope we all do it on a regular basis, so we review the literature systematically. The difference between a systematic review and a meta-analysis is that we use statistical tools to pool data. We use statistical tools to pool data. And that does only one thing. It increases your sample size. It increases your overall sample size. If your sample size is larger, it allows you to estimate the effect magnitude. So that basically means, let's say you have 5 studies that tell you early is good and you have 5 studies that late is good. The effect is 0. If you have 6 studies that says early yes and 5 studies early no, the magnitude is positive and is geared towards early repair, but the effect magnitude is low. In contrast, if you have 11 studies saying you've got to repair it early, your effect magnitude is large. And if your effect magnitude is large, you are allowed to extrapolate to the general population. What are the problems in meta-analysis? I just picked the 3 most common ones. Number 1 is publication bias. And all the editors are at fault creating artificial publication bias because we tend not to accept studies that have negative outcomes or insignificant results. And the most common argument for meta-analysis problem is the garbage in, garbage out argument. So if you have poorly designed studies with poor evidence, your analysis will also be poor. And the last is heterogeneity of the included study. So you have different study protocols, you treat different patients, you have different interventions, so it's very hard to compare and pool these studies together. If you ever do a meta-analysis, have a look at the Cochrane Handbook and follow the PRISMA guidelines. And the journal I'm involved in, I'm somehow becoming the bitch of meta-analysis, and I see lots of these papers on my desk, and it's surprising to me that less than 50% actually follow the PRISMA guidelines. So let's have a look at the studies available. Over the last 15 years, there were 8 studies that compared early versus late, more or less. You will appreciate that these studies are of low-level evidence, all 3 or 4s. The sample size is low, and the distribution is not equal. The timing for early reconstruction is similar, but the timing for late reconstruction is quite different. Follow-up periods are similar amongst the studies, but there are different interventions, and I just used the ACL-PCL here for the posterolateral corner and the medial structures. It's even more diverse. So once you've done your systematic review, once you looked at the studies, you need to judge whether these studies are of high or of low quality. So you use the grade assessment. And it's very easy to use. A randomized trial gets a high rating, and an observational study gets a low rating. And depending whether you upgrade or downgrade these studies, the quality rating is changing. And you have to do that for each of the studies. So what decreases the quality level? Basically 5 items: limitations in the design, indirectness of evidence. And you may ask, what is that indirectness of evidence? It's very simple. So you have a study that compares early versus bridging XFIX, and in the same study you compare late versus bridging XFIX. And the conclusion is early is better than late. That's an indirect evidence. And the other 3 are self-explanatory. What increases quality level? So we were talking about magnitude effect. If you have a very large magnitude effect, that definitely increases the quality level of your study. If you have an observational study and all 11 studies or 10 studies actually say you've got to repair them early, that's a large magnitude effect and increases the quality of that particular meta-analysis. Plausible confounding factors, if you can explain them, that also increases the quality of your study. So for example, you have a study that compares early versus late, but in the early group, you have a fellowship-trained sports surgeon who treats professional young athletes who have fantastic rehab opportunities, whereas in the second group, in the delayed group, you have the middle-aged recreational athlete that gets treated by anyone who is on call. So if you can explain the differences, this confounder, you can increase the quality level. Dose-response gradient is not so much applicable for us orthopedic surgeons, but rather for pharmacological studies. So let's go back to these 8 studies. And if you look at the level of evidence, the size, timing, and the follow-up, you have to downgrade each of those studies. Very simple. So from a low quality rating, automatically the quality assessment of all studies is very low. What's the next? You need to look at the risk of bias, and the risk of bias is described in the Cochrane Handbook. So what it does, it systematically checks each and every study for systematic error, or it checks the extent to which the results are correct. So in other words, it checks your internal validity. You just look at that graph. Red means bias, green means no bias, and orange means yellow means questionable bias. There's 6 items you have to assess, and you will appreciate that for these 8 studies, a risk of bias is certainly present. What about publication bias? Publication bias can be assessed by funnel plot inspection. So you just look for symmetry. Are the studies symmetrically distributed around the standard mean differences? And if you look at that graph, you will see, yes, they are symmetrical, so there is no bias. But I've tricked you here, because if you look at it very carefully and look at the scale on the x-axis, it shows you there's a logarithmic scale. So if you actually draw a triangle using the scale properly, you will see that there is publication bias in these studies. You can, to really quantify it better, you can do several statistical tests. It's a bit controversial. the main test you should use is the Eggers test. Publication bias can also occur with small sample sizes or if the studies are not homogeneous. So in surgery, in orthopedic studies, we can basically say all studies have publication bias because the sample size is simply too small. We're talking pharmacological studies with thousands of patients. So for this particular analysis, publication bias is present, and it is most likely due to a small sample size. What about heterogeneity? That's quite common, and there are three types of it: the clinical, the methodological, and the statistical heterogeneity. And the meta-analysis deals with the last one only. Important to remember, it deals with the last one only. How do you identify heterogeneity? You can do it three ways. Number one, you look at the forest plots. You look at the confidence intervals. And if there's poor overlap between the confidence intervals, you have heterogeneity. You can do it statistically by using the chi-square test. The p-value has to be less than 0.1. Don't ask me why it's less than 0.1. I don't understand it. It makes no sense. And if you have a high chi-square number in relation to your degrees of freedom, you can say that there's no heterogeneity. The simplest way is really to use the I-statistic. I'm not going into details of I-statistic, but it's very easy to say. It's expressed in percentages. If it's low, heterogeneity is not present. If it's high, it's present. So let's look at the clinical outcomes of these 8 studies. So you have a fairly low SMD. The confidence intervals are narrow. It's highly significant, and there is no heterogeneity. So you could say, based on this forest plot, there is a clinical significant difference between early and late treatment in favor of early treatment. What about range of motion? It's not significant. There is some heterogeneity. The confidence intervals are wider, and SMD is very low. So for range of motion, it makes no difference whether you treat them early or late. What about categorical findings? You look at the IKDC, your chances of having a near normal knee is much better if you treat them early and not so good if you treat them later. It's significant, but you look at the chi-square data, it's 8.85 with 7 degrees of freedom, so only 2 points above the degrees of freedom. It's not very strong evidence. So let's summarize. We had 214 studies, only 8 were included, 260 cases. The majority of them were early. The grade assessment was very low. Risk of bias was present, and publication bias was present. So early treatment results in significant superior clinical outcome, and there's a trend of a better range of motion. This is really the first time a meta-analysis has been done. It's low quality, so any study that will be published in the future may completely reverse that trend 100%. And as you always read with any meta-analysis, high-quality studies are needed. And that tells you something. It doesn't tell you that the meta-analysis is bad. It just tells you that the data is not sufficient. There are some controversies around early versus late. The definition is somehow arbitrary. It's 3 weeks. Why not 10 days? Why not 6 weeks? No one knows. That's a definition. And as the previous speaker said, there is a significant difference between the different knee dislocation. A knee dislocation is not a knee dislocation. So this is the conclusion of this meta-analysis. The results of this meta-analysis suggest that early intervention in multiligament injuries of the knee produces a significantly superior clinical outcome compared to late reconstruction. Fact. Although an overall trend of improved total range of knee motion was also demonstrated, this was very small and unlikely to be clinically relevant. Now, what's the real conclusion? That is the official conclusion. What's the real conclusion? What should I do? Should I fix them early or late? And the answer is whatever you like, because there's no evidence. But early is better. So before Michael starts telling us what is being done in South Africa, I just thought I'd give you a very quick overview of how I treat these patients. Early surgery within 2 weeks, I reconstruct the ACL, I always use allograft, I augment my PCL with a last graft, I assess the PLC openly, if it's suitable I repair, If not, I use an allograft using the modified Larson technique. If I have any issues with stability of my repair, I augment my repair with the Larson technique, and I augment my MCL with fiber tape. Thank you.
Thank you very much for summarizing controversy. So now we know to fix them early, and how we're going to do it.